Welcome to our webinar, and it's reflections on the pediatric health experience through a trauma lens. My name is Kim Driscoll, and I'll be your host for this afternoon. Before we get started, though, I'd like to take a moment to acknowledge that we, the New Brunswick Adoption Foundation, are a provincial entity. We acknowledge that we carry out our work in the traditional unceded territory of the Wolastoq, Mi'kmaq, and Passamaquoddy peoples. This territory is covered by the treaties of peace and friendship, which these nations first signed with the British Crown in 1726. The treaties did not deal with the surrender of the lands and resources, but in fact recognized Mi'kmaq and Wolastoq titles and established the rules for what was to be an ongoing relationship between nations. We, the staff and the members of the board, pay respect to the elders, past and present, and descendants to the land. We honor and acknowledge the keepers and seek their guidance as we strive to develop closer relationships with the Indigenous people in New Brunswick. As an organization focused on vulnerable children in the care system, we express these words with both humility and hope. Our webinar today aims to describe when and how children in care or newly adopted are assessed in a pediatrician's office. The webinar will describe the more traditional medical approaches and more innovative practices and focus on the trauma-informed lens. I'm very excited to have Dr. Sarah Gardner, our Gander, social pediatrician at the Pediatrics on Princess Center, and faculty at Dalhousie University and Memorial University of Newfoundland. She is here with us today to help understand this topic a bit better. So welcome, Dr. Gander. I am so excited for this. It's such an important topic, and I'm going to hand the floor right over to you.
Thank you, Kim, and thanks to the organizers for having me, and thanks for everybody for coming on a nice day. It's really quite flattering to see so many people here wanting to have this conversation. And in a minute, I'll share my slides and we'll kind of get started. But as Kim said, if you have any questions or you want to kind of interrupt me so we can in the moment have a conversation, then by all means, please do. And there'll be loads of time at the end to ask any questions that you have. So it's kind of fun. I recognize a few names here. So sometimes that makes me more nervous because then I know it's people who have come, but hopefully also some friendly faces I think I see in the crowd. So thanks for coming. So I'm going to share my slides and we'll dive right into it. Okay, guys. So when MB Adoption asked me to speak today, typically I'll give a talk about social pediatrics or trauma, and I really thought that maybe it would be interesting to have a conversation on exactly what happens when folks come to the office with a referral or with a kiddo that's getting kind of an assessment in different stages of the process of adoption. And and just sort of the disclosure there is that this really isn't something that is part of our training. We're trained very well to take a history, to do a physical, to troubleshoot sort of the differential diagnoses of problems. But nowhere in my recollection of my training did someone kind of sit down and outline the special needs or considerations, I should say, around children in care, and certainly not in the more specific adoption experience. And so most of that comes from being a pediatrician here in St. John, New Brunswick for almost 17 years, and really actually trying to do business a little bit differently because at MB Social Pediatrics, we pay particular concern to those kids who are living in poverty or have had toxic stress. And as I'm sure you can imagine, that includes our kids in care and many of the kids who end up being adopted or being eligible for adoption. And so it certainly is a major part of my practice to see these children and families, and to have experienced sometimes the family prior to kids going into care, while they're in care, and then after they're adopted, which is a really kind of nice part of my job to see a trajectory, in the instance when it becomes very positive, which I'm happy to say is often and can be often the case. And so I'm excited to share my experiences with you guys a little bit, and then answer any questions. So you probably don't need me to give you too many of the statistics or anything around adoption, and there are better experts than me in the room on that. But what I wanted to cover today was sort of the pediatric referral. So as a pediatrician, a little bit about MB Social Pediatrics, the appointment that you would have when you're there, the collaboration, and then just some other considerations. All the while, like I said, happy to take any questions. So just to give perspective of the amount of children currently in care, this is, I just got from the census data, our big numbers of kids currently in care eligible for adoption, and then not really sadly matching the amount of adopted children every year. And the reason why I thought I'd share this is just trying to understand the numbers. And so I would say that, probably a third of my practice now are kids in care, and then probably another third are supporting children who have had permanency in some way, and that might sadly include a group home, but then are not necessarily going to be adopted. Do I notice a little chat? Okay, that's you, Kim. So those are big numbers for me. We get several referrals a week. Pediatricians in general get, without sharing all the numbers, because it just sort of outlines the difficulty, certainly we get more referrals per week than people we can see per week. And so in New Brunswick, pediatrics is a specialty. It's not primary care, but with the primary care crisis, 34% of our kiddos don't have family doctors or nurse practitioners. So we're trying to provide this care, which usually ends up being a mix of new referrals, ongoing follow-ups, and then the kids that we follow over a long term, because they're really sort of challenging to discharge to a primary care provider. So that's my other disclosure, is that a lot of what I'll talk today is not necessarily needing to be done by a pediatrician. And so we never want to be a rate limiter to getting kids the access to care that they need. But I do think we'll all agree that in some situations, there's some specialty care that we feel we have a role to play in supporting children and youth and families. So it's not a small challenge. And so for me, what that means is it's an important challenge, and certainly one worth advocating for in terms of resources and support. So, my slides are lagging just with my buttons.
Do you mind, Sarah, if I interrupt for a moment there?
No
I'm
problem.
not too sure if it's sometimes when you're getting close to the mic or not, but we're getting some feedback when you're using
Oh,
certain words. When you sort of sit back a little bit, we're not
okay.
getting it. So just let you know.
Okay. Well,
Thank
I'll try to
you.
stand still, which for those who know me is challenging, but I'll do my best. Does that sound okay right now?
Look, it did still have the same, but that's no, if you go back further a bit, that's all.
Oh, okay.
There you
Maybe
go.
it's echoing when I get
Yeah,
too
there you
close.
go. Thank
Okay.
you.
Sorry, everybody, especially those with earphones on. Um, and just to further emphasize why, we think that we have a role to play, there's actually clinical guidelines, both from, well, the American Academy of Pediatrics. So this is our kind of go-to for where we get the guidelines for why we do what we do in sort of the traditional sense. So in the traditional sense, the American Academy of Pediatrics has acknowledged that pediatricians have a role to play in the comprehensive health evaluation of a newly adopted child. And that would extend, actually, they have guidelines around kids who are new to care. On the minister, and then also the Canadian Pediatric Society has extended that to include the special considerations of international adoption. So a lot of what I talk about today, my lens tends to be more, New Brunswick born children or Canadian born children who are in care in the adoption, who are eligible for adoption or have been adopted. But more and more, and if you ask me what like the biggest challenge in pediatrics is today, it is trying to meet the needs of newcomer children. So I see that I spelled Canadian wrong when I wrote that, so that's a little awkward, but to illustrate the point that there are very clear sort of guidelines about what's expected in terms of both those assessments. So, and I just wanted to make a note too that while when I typically think of adoption in the traditional sense, you think of a non-biological family welcoming a child into their home. But I would also say that a large proportion of the kids that I see are in kinship arrangements of some kind, and quite a few, it's the grandparents raising children. And I think that that is a population that requires even different considerations on top of everything else, only because there's many of them. They're disproportionately female, which would be true of a lot of sort of our lone parent families as well, First Nations heritage, and people who have left the workforce and are now trying to raise children again, which just simply from a financial standpoint is a big consideration, and largely in a lot of cases living with a disability and living in poverty. And so those become again social determinants of health for not only the child but the guardians as well. So just kind of a note there, just to keep in mind that sometimes there's that little extra bit too. So I thought I'd talk a little bit about the components of an assessment when you go and see a pediatrician. So maybe I'll just even back up and say, like, how do people even get to me? So because I mentioned over a third of patients that we see do not have access to a primary care provider, one of the things I'll talk about in a bit with MD Social Pediatrics is, pardon me, the ability to take referrals outside of just another physician. So traditionally, and Medicare is set up by which you can only get a referral from another physician or nurse practitioner. And COVID loosened the reins on that a little bit, and we were able to get referrals from speech language pathologists, which was helpful for sort of our early recognition of autism spectrum disorder or concerns around kind of early development. So that was very helpful. But in social pediatrics, we really extended that to be, frankly, anyone, and that includes self-referral. With a little bit of fencing around that, just because we don't want to skip over primary care providers. So we try to make sure that we include everybody that's involved in that family's life. But also just trying to facilitate easy access and good access to care. So traditionally, these are the stories where, social workers are sitting in the emergency department for hours and hours to see the emergency room physician just to get a referral to somebody for a child. And that still happens, unfortunately. It's different when there's an acute medical need, but really our Department of Pediatrics in St. John has taken a lot of pride in trying to work with the Department of Social Development, with community social workers, to try to make that more accessible and allow them to make referrals directly, or at least have a conversation about what they feel a child's need might be. And then that extends actually to other community providers. So I mentioned newcomers. And so, we get referrals from the newcomer connections, we get referrals from schools, which is really important. And then the, parents calling saying, I don't know where else to go. And, would this be an appropriate clinic for me or my child? So I think the first thing is just, how are we as a community breaking down barriers to get access to what we know is like guideline and supported recommendations for how we do not only diagnosis and assessment of kids, but even backing up to like the prevention and like, can we foresee some things that might be happening and kind of go upstream a bit. So just before I go into the rest of this slide, any questions about that or concerns or people, it's also an opportunity to like air your grievances and vent a little bit or anything, it's a safe space for that too. So Kim, any notes in the chat there? You'll let me know.
Not yet. We're all so engaged in what you're saying already.
Okay, good. So if we kind of take adoption as sort of that a moment in time, although it's a process, as I'm sure many of you realize, or you wouldn't be here. The pre-placement is typically kind of that time when, I know that there's going to be social workers in the crowd. So like, you guys know this process better than me, but my understanding of it is if we take a kid, so like say who's in the care of the minister, has gone through guardianship, is now in a position to like switch to the social worker who's in charge of adoption. And that person is trying to kind of like prepare the file, if you will. It sounds cool, but prepare the situation for like being eligible for adoption and trying to like find good pairing and matching out there. Um, that's an important time. And typically, what I would be asked as a pediatrician in that moment is to maybe do a summary of the child's care, their diagnoses, kind of how they came to that diagnosis, what the considerations are. And then while none of us have a crystal ball, I think it's really nice to be able to provide some kind of like, and this is what I would typically kind of see happen over the next little while, although obviously I can't see the future, but just to kind of give some sort of anticipation. They have autism spectrum disorder. They're currently involved with, Viva and as an intensive daily therapy. They're due to go to school next year. That resource will no longer be available, but this is what's available, and this is what we'll be advocating for in the next upcoming years, that kind of thing. So at least they know that we're thinking of what's happening next and that it's not all up to them to find that and advocate for that. And before all of that has happened, maybe I've known them for a while, maybe I haven't. But that's sort of a nice time to kind of put it all together. It takes time, also a lot of compassion for the social workers who are actually in charge of going through medical files that I may not have ever seen myself, and trying to read the chicken scratch of various healthcare providers and trying to put together the story. So sometimes our role is to be a resource to the people who are trying to put that together. And it's a lot easier for me to understand what a chicken scratch abbreviation is on a prenatal record than a social worker who doesn't have any medical training. And so it's really a pleasure to work with social workers to make sure we make that story as complete as possible. And and then also, because I'm sure many of us are aware that the healthcare system has multiple different um, electronic records. So people who kind of tend to go, I was born in Fredericton and then we moved to Moncton, and then we went to Ontario for a year and now we're back. Like, none of those systems communicate with one another. And so just trying to be available and be helpful when the people who are trying to gather all of that information, to try to make sense of it a little bit. So it takes a lot of time, but I do think that it's worthwhile time, because where it helps is that it eliminates, repeating investigations that may or may not be painful investigations, like blood work or whatever, expensive investigations, but also in that pre-placement or pre-adoption time, be able to reassure folks with some common questions like, have they been tested for Hep C? Have they been tested for HIV? Do we know anything about this, that, or the other thing? And so then being able to complete that story to the best of our ability is really a big important commitment to the process. And that's before you even start having conversations with prospective adoptive parents. Any questions about that?
No, but we do have a comment from
Okay.
an adoption social worker. They
Mm-hmm.
state that we do profiles for children at matching meetings, and social medicals are as important part of the file for disclosure.
Yeah, absolutely. And so most, if not all, of my comments are comments of compassion about how challenging that could be. Maybe sometimes it's not that bad. It's a little baby. You kind of know the whole scoop. But, I've been involved with, 8, 9, 10-year-olds who have lived in 3 provinces and, kind of went off the grid a couple times and things like that. And so just trying to recognize that we would like to be part of that solution to make that easier for social workers, I think is helpful. And then, because the psychological stuff we may or may not know the history of, but the medical stuff, just the files alone, sometimes a social worker will just send me a screenshot of one word and be like, what could this be? And I'm like, it's this word, and that just makes, saves them maybe a couple hours of time or makes the record more complete. So thanks for that comment. and validating my feelings about that because I just think it's a nice thing to do. So after all of like your best understanding of the child, kind of before they're even in front of you, of course, then there's like the history of whoever you can get the history from. And I have the privilege often of knowing either the biological parents or the foster family before they are in guardianship and eligible for adoption. And so just, keeping as good records as we can, being able to get as much information, and where that shows up as being very important for me medically, particularly is around the disclosure of things like substance use during pregnancy. Any of you who are involved in the fetal alcohol spectrum disorder kind of world of advocacy and whatnot, would recognize that disclosure and understanding of amount and timing during pregnancy is very crucial to the diagnosis of FASD and actually makes everything a whole lot easier, which in turn then benefits the child because we understand them better and can kind of get on with things. And so a commitment to asking the right questions when you have the opportunity and documenting those in a, respectful way, is really important. And so I'm always thinking, even if it's a child new in care and like we have every hope that reunification will be possible, it's just recognizing that when we can get the information and you have the people in front of you, then trying to do that. So that initial assessment, depending on whether or not that's with a bio parent, a foster parent, or sometimes the social worker alone is bringing a child. That really includes as much history as you can obtain. And then our style is also to speak to the child or youth about what their concerns are. So it's actually very common for children and youth to have their agenda coming to the office. So we think that we bring our kids to the doctor because of the thing that we're worried about. And that's true. But I have actually, well, maybe a couple of times, but very rarely when I ask a child, so like, hey, what did you want to make sure that we covered today that you have on your mind about how you're feeling in your body or in your mind or how you're like, everything's happening for you? Almost always they have some sort of comment. So it could be something just as simple as like, my toe hurts, or what's this red mark on my arm, which is like probably going to be nothing. To the chin quivers and they say, I read about PTSD on TikTok, and like, is that something that we could talk about? So like, that's an example that happened last week. So it can be like a nothing, or it can be like a huge, but to that child, because it's something that they identified, we really owe it to them from a child's rights perspective to listen to them, have their voice be heard, and to address it in a like, oh, it's nothing sort of way on your toe. No, but like, you examine the toe, you examine the foot, you have that conversation, because of course there's enough unknown in the care and adoption process. There's enough sort of you know difficulty with continuity that we just want to make sure that all of their needs are being addressed too. I believe in my heart that causes less problems later, because things don't kind of fester and they're not the same stress. So it does include a physical exam as well, and then and may include investigations or referrals to other people. In a perfect world, you would kind of have that social medical history provided as well, and have the social worker there, recognizing the schedules of social workers are bananas. And so it's really, in a perfect world, we're all around the table together. But I think I didn't put it here on the list, but ensuring that whoever the appropriate person is to sign a release of information so we can talk back and forth can be really helpful. And then, of course, you're reviewing results and you're doing ongoing planning and then ongoing follow-up. So it's, the title of the slide is more than one appointment. It's never kind of one and done, or very, very rarely. It would have to be kind of very simple. And so that's sort of just our commitment to trying to provide really comprehensive care for kiddos who are pre-adoption or going through the process, or if folks are finding themselves having never had any of that care, providing that assessment. So not every slide I'll talk this much, I promise, but how's everybody doing? Any questions?
We do have a comment.
Okay.
It says, I love your proactive approach and recognition of the importance of gathering as much information from the bio family in a respectful way to help the child for now and for later.
Yeah, it's really important. You get your list of pet peeves in our various jobs in the system, and one of them for me is we've done a poor job, all of us, and particularly the healthcare system, of documenting substance use during pregnancy and prenatal records. It tends to be a check mark, like, oh, they use drugs, check. Maybe somebody scribbles down what substances they disclose. Maybe there's a talk screen that's done in the mother or the baby at some point, but alcohol in particular tends to also be maybe a check mark. And fun fact, because I do research too, people are more likely to disclose that they use opioid pills or like meth and crack than they are to disclose alcohol. Because I think we've stigmatized alcohol to the extent where people don't necessarily disclose, but like meth and crack is still kind of just, people are willing to talk about it a little bit more, which seems counterintuitive. But our research would definitely show that. So just again, how are we having conversations with people in a respectful way? Because I've never really met a mother who didn't care about their child's outcome, even if they didn't think they were going to be the ones taking care of them. So it's all about how we then are able to take good care of their kiddo afterwards. It's not about shaming and blaming. And an opportunity to connect that woman with services, perhaps, that then, if they have subsequent pregnancies, we're able to, break generational cycles of substance use and substance exposure. So that's my soapbox about that, because that's obviously, for anybody who knows me, a big part of my research. So, okay, so moving on. So, common issues, however, that arrive outside of just we need you to help us, do a medical assessment for this child, are specific questions being asked of us. Does a child have ADHD? This is just kind of a top list of the stuff that I see. So, we kind of jokingly say the triple A, like ADHD, autism, and anxiety would be biggies. Other mental health conditions, maybe a physical thing. I say behaviors that challenge because, um, you know, we get a lot of referrals for behaviors around the time of major transitions. So, kids going into care, um, you know, maybe changing foster families, and all the things that go with that, and being adopted and all that stuff. And so, it'd be very typical to see kids have behaviors that challenge around that time. Of course, it's their way of kind of expressing them, and they're variable, they're expressing their emotions, and they're variable, difficulty with those based on what their trauma has been, or what their experience has been, or what their social emotional intelligence is really challenging. So sometimes people come to us with the like, I think they have autism, and really you're unpacking that and finding out that this is a transition time, and like making sure that there's enough support at that time, and then once the dust is settled, re-exploring if there's a diagnosis there, just to be fair, because you don't want to like throw labels if it's not appropriate. Lots of learning difficulties, and all of, I get those referrals a lot, just keeping in mind that pediatricians do not diagnose intellectual disability or learning disabilities. They're done by a psychologist with a psychoeducational assessment, which are very difficult to obtain through the public system, and often end up meaning that parents are paying for that out of pocket or with insurance, and they're in the range of $3,000 to $5,000, which is obviously, inaccessible to many, if not most. But where it becomes important is, and so this has occurred in my practice many times now, where people think kids have ADHD or they're not adjusting, and whatnot. And if any of you are in the school system, the healthcare system doesn't do an awesome job about communicating between centers and stuff. And the school system would echo those challenges as well. Like, a kid changes a school, and does all the information follow them, the things that worked, the things that didn't work, the things that have been tried to try to support them. And so then all of a sudden they land in a new school and none of their accommodations are there and whatnot. And so then the kid is acting out again or having challenges. And, is it Is it that they're having learning difficulties, or is it that there's a diagnosis, or is it just that they've lost their supports in that transition? So that's our job, is to try to unpack where the needs are. And then, what's happened in my practice is that then all of a sudden they get a psycho ed and you realize that their IQ is so, so low, but nobody really was able to follow through on those concerns. The teachers saw it, but they had so many transitions that just nobody could kind of get to the finish line of trying to get that diagnosis. So that, and if a child has an intellectual disability, it's a completely different management plan than if they have a learning disability or if they have ADHD, as I'm sure you can figure. And then substance use. So I thought I'd throw out a little stat, which is, so for our parent-child assistance program, which I'll talk about in a little bit, which is an advocacy program and navigation program for women who use drugs and alcohol during pregnancy. So that would by definition be problematic substance use, because most people know better than to drink and do drugs during pregnancy, but they do it anyway. And that's because of the power of substances and trauma in our communities and in our people. They tell us that, when we survey everybody, on average, they started their use between the ages of 11 to 14. So I'll often say out loud, substance use disorder, addiction, whatever you want to say, whatever words you want to use, is a pediatric problem. And so we need to get better about what we're doing in terms of screening our children and youth for substance use. And of course, why would we screen anything without being able to offer something to do about it? So what are we doing about it? And how are we supporting people? And what's the difference between problematic substance use? I mean, I'm a mom. I don't really want my kids doing anything, but do we care if kids smoke a little bit of weed every now and then? Is that a problem? Or, from a harm reduction standpoint, if they were doing meth last year and now they're smoking marijuana, well, then how are we supporting them to not kind of go back to a more problematic, but is there the goal of then not using any substances, or being very aware of their potential for addiction and things? So I think that is a pediatric problem, but it never used to be acknowledged as a pediatric problem. So none of us would have had training in substance use disorder for youth. But I can promise you that with the wave of the opioid epidemic across the country, we're now admitting kids for detox. We're admitting them with overdose. We're trying to put them on methadone and Suboxone to stabilize them in the community. And my youngest patient would be 12 that we've started to do that with. So they aren't necessarily in the adoptive, but just if we're going to talk about trauma, we're going to talk about adversity, and we're going to talk some of our kids at risk, this is the population that has the potential to, has a higher likelihood of having at-risk behaviors later. And so again, how can we try to screen, try to prevent, try to see it coming? So with the belief that might change their course a bit. So those are really common issues that we deal with. I'm sure there's more, and people would have better, other ideas too of things that they've arrived with, but that's a big one. I mentioned FASD already, which we're only beginning to understand in our province, because we know that there's way more than we even realize in terms of people who have been affected by alcohol in pregnancy. And that's a really challenging thing, because that's shown to be very generational.
Well, that actually brings me right into one of the questions. So we have a comment and a question.
Okay.
First, I'll do the comment, which it says, thank you, Dr. Gander, for noting how important it is to ask questions about substance use during pregnancy and properly documenting this information. Like you mentioned, it's not about shaming the mom, but rather having a better understanding of the child so the correct supports and interventions can be provided.
Yeah, no, thanks. I agree completely.
And the question goes along with your last topic that you just talked about is, what is your feelings on using the term medical diagnoses for FASD, as many parents face challenges within the school system who do not recognize FASD as a medical diagnosis, so they do not qualify for an EA?
Yeah, that's a huge question. Yeah, I'm tempted to just go on a little soapbox about the need for diagnosis to result in children getting support that they need. I mean, I think that the roots of integrated service delivery were that we were going to meet children where they were at and give them the support that they needed, regardless of their diagnosis. Um, you know, is that happening? I certainly could give lots of examples where that's not happening. But so I do get that quite a bit, and more than just FASD, like, autism, like, oh, you know, somebody calls my office and says, I need an appointment because we're trying to get this, that, and the other thing for my child at school. And since they don't have a diagnosis, the teachers say they kind of can't do anything. And even when I talk to kind of some people in kind of the uppers of they sometimes they don't believe me. They're like, well, that doesn't happen. I'm like, well, I can write it down for you and tell you all the stories, but I'd have to tell you their names, and then that's a privacy problem. So I think that FASD, not unlike autism in our world, and not that I'm saying that they're the same, but I'll say another statement in a minute that maybe people will find a little controversial, but um, is a neurodevelopmental condition. So that's how it lives in our framework in the medical world, that has very clear diagnostic criteria. And we have really clear Canadian born criteria that are like lovely people in our province, like the FASD Center, like Nicole LeBlanc kind of people in Moncton. So like who are very clear on what the diagnostic criteria are. And those include things that require a psychoeducational assessment, speech language pathology assessments, a medical assessment, and only then can the diagnosis be made. Of course, there's the history too. So this is a long answer to say that the diagnosis can't just be made, it has to be made with a team of healthcare professionals because those are the diagnostic criteria. And so I don't know if that does that answer your question that but it's very hard to get. The wait list for the FASD Center is years long. I can't just do it in my office because, like I said, it's a very intersectoral diagnosis. So you need a team. We've been wanting to do that for years. A very nice advocacy piece to government would be, hey, you paid for the FASD Center of Excellence X amount of years ago with the plan to scale. So what's the plan to scale? We have 125 kids on the wait list in St. John alone, and I think they do 8 or 10 assessments a year of St. John kids. So some of our kids are going to, age out, for lack of a better word, before they get those assessments. And so think of their time lost. So I think that like FASD is a very misunderstood and underappreciated entity that needs attention and needs that resource word. And the thing I was going to say about autism, and please always know that I say these things respectfully, because sometimes I say things out loud that are things that I hear too, and I think about and haven't always decided how I feel about it. But have you heard the expression, like, if you're white, you have autism, but if you're Indigenous, you have FASD? And so sometimes, so in the medical world, we call that premature closure, right? Somebody comes into my office who lives in Rossay, who's white, who's very well off, and they have their child with neurodevelopmental difficulties. Am I asking them the right questions about alcohol exposure in pregnancy, or am I sending them to developmental clinic for an ADOS to consider autism? Or am I doing both to be as complete as possible? Or is it possible that people, come in and they might be more stigmatized, whether it be they're Indigenous or poor, or, from an appearance standpoint, maybe they have substance use problems or something like that. You're thinking, oh, well, it must be drugs and alcohol during pregnancy, and you put them into that category. So it all comes down to stigma and bias. But I think the whole point of telling that story, because medical system is a very colonial one as well, let's get real, we need very robust and accessible assessments so we get it right, because different neurodevelopmental problems are treated differently and require different supports. And so, that's really the next mission of pediatrics, is to get really good at understanding that stuff and then the psychosocial supports and advocacy and that go with it. So that was a really long answer.
No, and that's great. And thank you so much. I think what they're looking for you to do also is clarify whether or not FASD, due to it being a neurodevelopmental disability, that it is a medical disability. Because in order to qualify for like EA assistance with their tier system, you have to have a medical disability. In which some schools still feel that or see FASD as not a medical disability.
Yeah, I don't know if I've heard the distinction about like medical for an EA. Like I've heard, there's the clinical teams, and you picture kind of a child who might have seizures or be in a wheelchair or like have feeds at school or
Yeah.
what have you, which would be kind of a more classic and more visible disability. Um, but I have I mean, kids with autism get EAs, kids with, other behaviors that challenge get EAs. So I, I don't know if it's fair to say FASD it's just not a black and white thing. It's not a binary thing. It's a medical thing or it's not a medical thing. It's a very complex piece. And sometimes there are very big medical concerns, whether it be seizures or maybe they require toileting help or things like that. Yeah, so not a black and white answer, more like a is that school assessing the child's actual needs and seeing how extra support will help them meet with success?
Yep. Yep. I
Because
think
no
that's
school should
good.
say
Yep.
only kids with medical problems get EAs. Like that just couldn't be a thing. They wouldn't be able to function.
Yeah. No, I think that definitely answers it.
Or they're a
Thank you.
school that's like sending all the other kids home or something all the time, which I won't get on a rant about. um, so um, so all to say that like the list of conditions that I was giving um, is a really hard thing to unpack because a lot of our kiddos that find themselves in a circumstance where they would be adopted have potentially, had their exposure to adversity. So I'm going to just assume that most of us have heard the word adverse childhood experiences before or ACEs before. But just in a one-line summary, the adversity that we experienced before the age of 18 has been categorized into 10 questions by which if you have a score of over 4, it has been linked to, as I have on the other side of the slide, significant increases in both physical and mental health conditions. And so, you can look it up and do your own ACE score. But, like some of the ones that, half the population tick are divorced parents, but you get into sexual abuse and incarcerated parents and mental health problems and stuff. And, oh, and like I have here, then your cumulative ACE score then puts you, and this has been proven time and time again, that then the rates of these conditions escalate for later. And I'll just say out loud that the ACEs have been revised to expand to include things like separation from parents at the border, racialized experiences, displacement or and things like that, which is obviously especially true in our newcomer population, but also would be relevant for our folks as well. So links to physical and mental health conditions, and then also behaviors, and sometimes this is where we get into some of those generational pieces around substance use and just kind of the cyclic nature of adversity playing out. So this is where it's not what's wrong with you, but what happened to you conversation happens, that we, I think should all agree stays in our nervous system no matter how young we've experienced it. Attachment is so very important, even in the first few hours of life. And so we just are recognizing that trauma stays in the system, regardless of how young you are or when you're kind of removed from those traumatic experiences. And we all have stress, and we're supposed to have stress, and that's important for us to build our strength and resiliency in life. But that these particular cumulative and in some cases prolonged and ongoing toxic stresses can really do a number on people's nervous system. And so I often ask myself, well, would they have had ADHD anyway? Or would they have had mental health problems anyway, maybe? Or is this secondary to the adversity that they've had? Again, who really cares? I care more about what we're doing about it. But to the comment earlier's point, sometimes you need to label things to kind of connect people to the resources that are available, which, personally gives me the ick sometimes. And so that becomes a very important conversation with decision makers for the children about, we're going to call this autism. I think it's more complex than that. It meets the diagnostic criteria, and it may play out different than what we know a traditional autism diagnosis to be. Or maybe we'll find out, all of a sudden when mom discloses in some trusted conversation, or is in a better position to do so later, that she did have, alcohol exposure, and then we can change our mind and kind of, adapt as we go along. So that's a lot of the patients that I see, is like, as we gather more information, maybe we change our mind, maybe we, but just being really transparent and open when you're having these conversations is really, really important. And still, a lot of the treatments and medications and things work for the problem, so that's fine and well. But just being like, I don't think this is just straight up ADHD. I think, we know there was trauma and toxic stress there, and now they're presenting with all of these traits. So, we're still going to probably do the same thing about it, but let's always keep in the back of our mind that this may not be a typical course of ADHD like we would see in a different patient. So any questions about that? I think I saw one chat number increase.
Yeah, we do have a question saying, what about applying for disability tax credit? Do you know, does FASD, etc., qualify you for that?
Yeah, so in my experience, it does. The tax disability form went from 4 pages 2 years ago to 16 pages. And most doctors you'd think would complain about that. But actually, the form got a lot better in terms of being able to describe what people's actual needs are. So the doctor component of it is very clear, because it ends up being in the mental health functions for life kind of section. And there's a couple of pages of where the dysfunctions happen, and you have the opportunity to give examples. So yes, the diagnosis can be important for the tax disability form, but what's also important is a healthcare provider, because it doesn't just have to be a doctor that fills them out. Psychologists can, OTs can, stuff like that. Usually doctors do it because if we're salaried, we don't charge people for it. But all to say that having the example, so having parents write out exactly what their experience is. So like, we were denied a tax disability credit in a kiddo that I had who has an intellectual disability, and I was, to use a Newfoundland term, just like rotted that, I had to fill out the form again. And I looked at this child and was like, are you kidding me right now? And so when we got it approved, it was because we wrote examples like, despite being reminded and a visual reminder, this child continues to put like aluminum cans in the microwave because they just can't, put that together. So there's like safety concerns. So, they're 13 years old, but they need to be supervised 24/7 because there's major safety concerns. So like using those kind of examples and stories are really important. And then the other thing about tax disability forms is that when they arrive at CRA, they just like arrive on some random person's desk. Like it's not a uniform process that then, so sometimes I'll just like send it again next year with a little bit more and it's approved. So there's a little bit of subjectivity there. So just make sure it's as complete as possible with as much information as possible. Even a copy of the assessment, if it's been done, can be helpful. And then if it's rejected, filling out the appeal questions and reapplying. Another long answer.
Great. Thank you.
So, when you have adversity in childhood and you've adopted, you have this person, you have this adopted person, and you're like, well, I know that they've had all of this adversity. What the heck can I do about it? I can't go back in time and change their experience. Where the research is going now is to positive childhood experiences. So, just to pause on this quote for a minute, which I found when I was making my slides, is just again to illustrate the point that even if we get kids from birth, the cortisol release and the stress during pregnancy has the potential to disrupt the nervous system as well. And again, this is an area of research that we're only beginning to understand. And I kind of cringed with this slide a little bit because you don't like saying things like this unless you think that we can do something about it. And so when I wanted to talk about the positive childhood experiences, which are all things that like our beautiful foster families or, our good social workers, our adopted families are doing, is creating an environment that has, a safety and, a lot of my action plans for kids in the clinic are like, are they in music? Are they playing? Do they have free play? Are they, what sport are they interested in, if that's it, or creative arts or whatever? Like, what are these enriching positive experiences? Because the beauty of kids is that their brain, connections are so malleable that we have the opportunity to change that story. And that's why some kids can have the same terrible experience and some do okay and some don't, is because something has happened there. And, what was it? Was it having that one coach? Was it having that one teacher? Was it, getting in an environment where, if you see, this is some of our research, the decrease in the odds of depression and poor maternal health in mothers as you increase the amount of positive experiences. So you can actually impact diagnoses with those positive, which we all know, right? Like we all know that when you have, even just on a small scale, a bad day, like having a conversation with a loved one, being invited to something, going out and having, our exercise or whatever it is that fulfills us, can turn that around a little bit. And that's what we can see on a much bigger scale when we're dealing with trauma and adversity. So that's really exciting, because then there's research that shows even though pre-placement adversity increases an individual's risk for maladjustment, the human brain and behavior are so malleable that when you're placed in a nurturing adoptive home, it actually helps recover from that early adversity. And that might be different for everybody because brains are weird and brains are different. We don't completely understand them. But what we know is that those positive experiences in a nurturing home and environment are crucial. And so the cringy slide, the story for me is actually, there's no evidence that early adoption is a trauma for an individual. It's really, what are we doing next with them that is going to be the true story now that we have the opportunity to do better. So hopefully then that's a hopeful end to that piece. And so then that's ACE prevention. So this slide, I think, is important because it makes me just recognize the degree of stress in foster parents and adoptive parents. And so I think, you guys, again, would know better than me, but maybe there's just this feeling like, oh, they're adopted now and like they're in your house and everything's good. And so I definitely think that was probably how I would have felt coming out of training was, oh, good, they're adopted, they're good now. And then you sort of get some experience and realize, whoa, this is a whole other change and maybe even, dare I say, trauma being another transition, and not just for the child, but for the family, because we know that guardian mental health is directly related to child mental health. So are we making sure that families have good economic supports? These are adoptive families. Are we making sure that like the marriage of the guardians or the relationship or the support network is strong and there and being able to be cultivated? Are we making sure they have access to things so they're not having the additional stress of like, well, who do I even see for that? Or how do I even navigate that? The system is terrible, right? And then are they able to keep doing their activities so they have their positive experiences so they can fill their bucket to show up for this adopted child that's now in their home and experiencing a lot of change and emotion. So and then preserving that placement if it's the right thing for to happen, is just really important. So that's why it's not sort of like see you later alligator, and we see people for quite a long time after, just to make sure those transitions settle. And so I just think that for me, I get really excited for adoption at any age. And I think that brains and kids, and it's really probably why I became a pediatrician, is that they're so cool and neat. And, it's such an opportunity to both learn from kids, but watch them grow and be able to intervene in a way that's positive. And, we have so many youth. Um, that are not kind of connected to adoptive families, and I think that's kind of the one that I really think about and sort of think, some people think it's kind of too late, and I hope we get to talk about that a little bit because you guys have more experience with that than I do. But you know I don't think you turn 18 and all of a sudden you're able to be out in the world without any support. And so I'm just a big fan of some of the work that the Center for Youth Care is doing around supporting kids who, for lack of a better word, age out of care. So hopefully you agree. But I'm happy to talk about it because I worry so much about my youth kiddos who, I say goodbye to at 18 because that's what I'm mandated to see. And many of them are going out into the world without even a family doctor. So just I think about that a lot. There's a lot of kind of moral injury there when you discharge patients at 18 to basically nothing. So I also think that, just to kind of, and then I'm going to talk, then I'm going to do shameless self-promotion of our programs, just so you know about us. But this is kind of my last thing. But community services and connections are really, really important. So to build autonomy, both for the youth, but for the families, that we don't necessarily have all the answers. And I obviously learn a lot from families too about what they've experienced. And so we do, I'm just going to stop sharing this for 2 seconds, because when I tell you about social pediatrics, I'm hoping to, this will be on our website, and it's an updated community service manual, which is probably a little bit of St. John heavy, but also meant to be for the province. And it's meant to be a resource that we've kind of gathered over time, a living document that will change on the website. But it has things like law information and child custody and just some information and access to things that we have found over the years people want to know about. And so there's medical things, but there's justice things and education things and housing and stuff. So this is kind of for all comers who come to us. But maybe we need an adoption section. I don't think we have one. So maybe you guys can help me with that one. But there's lots of sort of different things here, teen and youth community resources. So we're always building that with the recognition that the system is really challenging to navigate. And there's some wonderful resources out there, but you just sometimes can't find them. So, so NB Social Pediatrics is now a charity, but an umbrella organization of a lot of different initiatives that I started with the Department of Pediatrics. And I get to always remember how long, because it was when I was on maternity leave for David. So he turns 8 in January. So we've been around almost 8 years. And it was really about recognizing, with the kids in our community in St. John largely living in a nearly 50% child poverty rate, that our traditional medical training was not meeting their needs, and that we wanted to be part of the community solution, to have them reach their full potential. So I think I told you a little bit about our style for appointments. I think our record for how many people who have come to an appointment with a child is 14. So that's why we have the center that we do, and that a sterile little doctor's room with 3 chairs doesn't really cut it when you've got, mom social worker, dad social worker, the teacher, the occupational therapist, Grammy, the 2 siblings, me, my medical student, the social worker we have, like the group of people who are trying to work around this child, it saves a lot of time to be having that conversation in one go, and putting the child at the center of that. So that's kind of our ambition, and doing so in a way that means then it's not a whole bunch of conversations and meetings separately. And sometimes this happens in the school. So it often happens in the school, actually. And that it's an umbrella organization that, yes, has tailored services for families like my clinic, like the Parent Child Assistance Program, but also we try to monitor outcomes with a research program, offer ideas for different policy change to government, see gaps in the system around community programs and try to develop those. Lots of students, not just medical students, social work students, IT students, medical administrative students, nursing students, we've got it all. And so just really trying to spread that word around community engagement and participation. And so, of course, there's the advocacy piece. Did I see another number in the chat, Kim?
Yes, we do. We have a question, and it
Okay.
says, can you explain if there are doctors and pediatrician clinics and or services across New Brunswick that are similar to your clinic and approach?
Thank you. So we were actually not the first in New Brunswick to come up with this idea. So any of you guys in sort of the Dieppe, Memram, Cook, Bouctouche sort of area might know Elaine Deschênes, who is the sort of first social pediatrician outside of Quebec and in New Brunswick, because we didn't dream this up. It actually came from a model in Quebec and Dr. Gilles Julien, who recognized that our kids needed more than just the traditional model. And in the 90s, got out of his office and on a bike and started having these conversations with families around the kitchen table. So you hear about the kitchen table approach, and that's kind of where that vibe comes from. And Elaine brought that to the Memram Cook area, and has encouraged the involvement of primary care. So Elaine has stopped seeing patients now, is my understanding, but she has several family doctors who have continued kind of that charge and has the support of social work. And so that exists there and is part of Vitalité. So then becomes accessible in French in a more complete way than what we would provide. And my whole raison d'etre right now is to try to scale this. So my catchment area is Sussex to Charlotte County. So I go to Graham and Ann. We say it's the POP clinic, right? Pediatrics on Princess. So you can pop in, and we have pop-ups, so Charlotte County, Sussex, Graham and Ann, to try to bring it out into the rural communities. But actually right now we have a proposition in front of the government to create a framework where we can look for local champions to bring this to other areas. So we've had like a women's shelter in Fredericton reach out to us. We've had one of the wellness centers in Miramichi reach out to us, but we want to make sure we're so solid that we can mentor those champions to do what their community needs, because it's not my community, so I can't really just jump in there and tell people what to do, but we're willing and ready to mentor any site that might be willing to do this, because I don't think it has to be a specialty trained pediatrician. I think people could learn the skill, and a lot of the skill is just compassion and like understanding the system and that kind of stuff. And so I think there's lots of opportunity to scale. And so we actually met with, not to be fancy, but the Premier and the Minister of Health last Wednesday to try to pitch this, especially before the election, to see if they can really dig into that. And so we really want to see where that might go, either with the same government or if there's a change in government. And so we've met with Susan Hold as well to sort of say, like, we're ready. We believe that this is important for children and youth in our province. And so fingers crossed. But thank you for implying that it should be in other places. We would like that very much. And so we do a lot of research, and the commitment there is to just not continue to do something for the sake of doing it. And so we really enjoy looking at our outcomes and kind of adjusting appropriately, and also being able to show funders and donors and taxpayers that the money that's going into what we're doing is actually changing results, because we want to definitely make a difference. So I mentioned the parent-child assistance program, and so these are some of our advocates who, on the right to me, so like sitting at the desk here, some of our advocates that work with clients who are using drugs and alcohol during pregnancy, and so many of those kids are no longer in their care, but this we know that women who use drugs and alcohol have at least 3 pregnancies in their lifetime, usually and often more, and so maybe their early children have been adopted, but there might be siblings coming behind them. And so we make it our business to try to ensure that those siblings have as little drug and alcohol exposure as possible and try to stabilize moms, because maybe then they get to be unified and stay with those moms. But at least as individuals, they have kind of the best start. So people say cradle to career, and we say conception to career because we think healthy pregnancies are really important too. This is the Pop Center. And so this is Pediatrics on Princess. We've totally outgrown our space. We're sitting on top of each other, but we love it and we look forward to expanding soon. One of our programs that we really saw a gap in is youth and cooking. And so this is a youth led initiative where they wanted to learn how to cook in the clinic. And what we did is build a curriculum around that, around healthy boundaries and consent and stuff like that, just because a lot of their experiences have been negative around relationships, even just friendship relationships or things. And so we really enjoy that. And so this is just me and Destiny sitting on the floor there, who's our program coordinator. And so we actually just offered this for our PCAP moms, and it was a huge success. So these are kind of some of the things that we're doing. Creative Expressions is a social emotional group for 8 to 12-year-olds. So we offer this at the Pop Center, but we also actually went into St. John the Baptist and did 2 sessions, and anyone's welcome. So these things, they don't have to be a patient of mine. It's just we usually do a Facebook call out for people to get involved. And, this is largely kids that just need a little bit of help expressing their emotions. And it's done in like different art. What's the word I'm looking for? Like summer paintings, clay, that kind of stuff. Lots of mentorship, as I mentioned, with our students, and lots of advocacy. And so that Cooking Up Justice class, you'll see that there's some municipal people from city council who came, and leave it to youth to ask the tough questions. Like we left it to them to kind of put them on the hot seat. And it was really fun to watch them ask really important questions. So I think, again, bringing people who are having that lived experience to the decision makers and policymakers holds a lot more weight than just kind of some doctor complaining about what she's seeing in her office. So. And our big current research project now, which is taking a lot of our extra time, is understanding those generational pieces around substance use and trying to look at evidence of breaking those cycles. So that's a little bit about what I do outside of just seeing patients every day. And I hope that I gave you an idea of what pediatrics is like for us and for the kiddos that we see, and for the kids that you got, children and youth that you see. And we're always open to feedback, and you don't know what you don't know unless somebody tells you. And so if a lot of people in this webinar are professionals, then please get involved. Please reach out to me. Please offer your expertise so we can only just collaborate and be better and better. So I kind of said my talk was 45 minutes. It turned into about 70 minutes, I think. So I think we have some time for questions.